Can everyone hear me?
Yes.
All right. All right. So let's see. So this is a 77-year-old woman. Complaining of decreased vision in both eyes. She's been complaining of worsening vision, mainly her central vision. She's having trouble reading, and she notices some of the letters are missing when she closes one of her eyes. This has been going on for a couple of months. She describes a foggy circle in her temporal vision when driving. She says it's sometimes intermittent. Past medical history is hypertension, hyperlipidemia, depression, spinal stenosis, osteopenia, psoriasis. Vision is 20/32 in the right eye, 20/20 in the left eye, and IOP is 13 in both eyes.
So we have a fundus photo of the right eye. The media looks clear. Nerve looks sharp. Maybe 0.3 cup to disc ratio. Vessels look largely within normal limits. And then your attention is drawn to the macula, where there appears to be kind of like atrophic spots. And then a color fundus photo of the left eye, kind of very similar presentation. Attention is drawn again to like the atrophic hypopigmented areas in the macula.
There's more there, yes.
Oh,
She'll get it. Yeah, go back to the second one. She'll get it.
Yes.
A little hard to see. You feel the light. Well,
are there pain in the area as well, centrally?
and then down inferior macula, there's these other spots. What color are those?
They're almost like ugly product.
Yeah, you can just say they're yellow spots.
Yellow spot.
You can say red, a little red, a little yellow. Because I saw it this week. I have a patient with red spots look just like that have been there for 2 years. They can't be hemorrhage. It must just be a vessel. I called it hemorrhage at first, then I changed my chart because it's like you can't have blood in the same spot that long. So you can say red, yellow, elevated, dark, sharp, whatever.
I'd be careful about calling the second image atrophic, because when you look at this, you can see the vessels underneath, but in this one,
Oh, good, thanks, yeah.
you can't.
Oh,
So just call it hypopigmentation maybe,
yes, yeah.
versus the first image, which is definitely the atrophy. Okay. All right.
And then this is an OCT. I'm not sure which eye.
It's like a right eye. We always do right eye first. This is a vertical cut though. Usually I try to get you horizontal. So you probably didn't have a good horizontal.
Okay.
There's the horizontal as well. So there's one vertical and one horizontal of each eye.
Okay. You start with the right.
Right eye vertical.
Vertical, you can see that the outer layers seem disrupted, the ellipsoid zone, maybe RP pigment migration anteriorly. And the foveal contour looks a little bit distorted as a result, just a tiny bit.
Now, what do you call these white areas on the back? You can't see it on the internet, but on the left side of the image, of these below the RP, it gets very bright right there.
Are they hyper reflective, like artificial?
Hyper transmission.
Transmission.
Good. So you get hyper transmission there, and then some people call it reverse shadowing. I think the term now is hyper transmission. And then, so that's a very important clue for geographic atrophy, and that's the most reproduced or agreed upon. So if you show this image to 10 retina specialists, they might say there's, loss of the external lining membrane. They might say the ellipsoid zone's funny, but they're all going to say there's hypertransmission. So for grading and for scientific purposes, hypertransmission is kind of the OCT biomarker. And then, is that a double layer sign? This is a hard question. You see where this splits?
Oh, you mean in the center? Or
Yeah, in the center. I'm sorry, you can't see on the internet. So in the center, the RPE and Bruch's membrane split there. For probably, I don't know, 1,000 microns is kind of irregular. It's not, it's not really a double layer. So there's this double layer sign that is very correlated with CNVMs. It's got to be a little bit irregular. So it's got to be, you have to have a double layer, but it has to also have irregular reflectivity. And this, it has to be a certain size. This doesn't quite count. So that's probably just confluent drusen there in the middle, but probably not a CNVM.
I have a good slide on that later in the presentation comparing.
Okay.
So some images that kind of what is and what isn't too.
Okay, you can keep going.
This is right eye horizontal cut.
Cut, I think very similar disruption of the outer kind of layer, the ellipsoid zone, maybe some, again, some drusen, peripherally or temporally and nasally.
Very good.
Transmission.
Yeah, you can say I forget. The more you say it, the more I remember it. I think that's what I remember it that way.
Let's move on to the left eye. So this is the left eye vertical cut, I believe. Wait, yeah, maybe actually horizontal cut, I think.
Again, disruption of the outer retinal layers. There's some subretinal like fluids in areas, as well as intraretinal pockets, cysts. And are those white spots again like RPE, like the pigment migration or
Intraretinal.
Mhm.
See, that's where it's hard. So those could be, it's macular degeneration, could be pigment migration, but you also saw yellow spots on the scan, so it could be exudates. So that's why you're safe is saying
Yellow.
intraretinal hyperreflective spots, dots.
Okay.
Karina, was it intraretinal hyperreflective? Foci. So that, those are intraretinal hyperreflective foci. IHRM.
We have another OCT of the left eye. This is a
Similar presentation again, disruption of the outer layers and drusen, intraretinal hyperreflective foci, and some hypertransmission as well.
And she can't, if she points, you guys can't see it, so, Vishnu, point to where the subretinal fluid is, so everybody can kind of see it. So that dark stuff's the subretinal fluid there. And then the RP, you said drusen, but they're also, point to where there might be a membrane or something. What's that white line, the bright white line there, Eunice? Do you know that one on the back? I'm pointing to it, the straight white line below all the junk.
Is that what?
Yeah, that's Bruch. So in some of these images, you can see Bruch. It's probably more accurately the basement membrane of the chordae capillaris, probably. So it's probably part of Bruch's, but you can only see that in these images. So when you get an OCT, you get your raster scan, which is your, but then you also can get these two high definition lines. The high definition lines are a sum of about 100 images. So you get much better resolution. So all my patients come in with the raster and the two high definition lines, because there's stuff you'll see on the high definition line. Like I've had patients where I was sure there was subretinal fluid on the raster scan with the myopic tractional maculopathy or something. And then on the high definition line, there wasn't. It just, you just lost the signal. So the high definition lines are nice for that kind of thing. They're nice for teaching too.
And then this is for seeing angiography of the right eye. You see hyper fluorescence around the areas that seem to correspond to the atrophy, areas of atrophy on the color fundus photos. And then also some foci of hyperfluorescence as well surrounding the area.
So you have a early and then a 10-minute one there. Is that, what kind of hyperfluorescence is that? You got 5 choices, right? There's staining, leaking, pooling, window defect.
a window defect.
Good. And then, yeah, those are probably window defects, and so it's probably not leaking, because why do you say window and not leakage?
Because the borders maintain the same kind of size.
Good, perfect.
And they're sharp, and
They're
they're
sharp,
fuzzy.
yeah.
And what is staining there is the sclera. The fluorescein is slowly coming in from the side, from the choroid capillaris, which is, the choroid capillaris is a sieve, doesn't contain fluorescein. It leaks through.
That's a really good window defect example.
If you got a really early one there, you'd see that the fluorescence is coming in from the side. As the choroid
It would be
capillaris
dark
comes in.
early.
Because the big choroidal vessels are competent for fluorescein.
And then again, a fluorescein angiography of the left eye. This is hypofluorescence, but would this be more with leaking as well?
Yeah, so you got 20 seconds on the left, 10 minutes on the right. So you're looking for changes. So what makes you say leaking?
Because the areas get progressively kind of brighter, time passes.
Well, this one will too.
Spread.
Spread, yeah.
Mhm.
So the more margins not sharp, kind of spreads. Now, it can, pooling and staining are a little bit of a pain in the neck, and so, but this definitely leaks. It's probably leaking into a pool, but that's probably more leaking. So this is probably pooling. So this guy, so the top one, you see this, no, you can't see me on the internet, but the lesion, these three lesions on top, that all early and late are probably staining. So those are probably those PEDs that are staining all the drusen. And then the one just to the left of the fovea is probably the one that's leaking. So you probably have staining.
We have staining on this side, you have leakage on the other side too.
Yeah.
This is-
on the right.
This is the old word, it's occult.
Yeah.
And we used to, we used to treat these if you were stupid.
Oh, with the hot laser.
Yeah,
We thought you noticed.
and it was like pouring oil on a fire.
Yeah, we actually, I have a retina specialist in my neighborhood who, lasered an ophthalmologist's father came in with, an occult lesion with a hot spot. He thought it was the whole membrane laser, his vision went 20/40 to 2200.
Yeah, look, I've done worse
Like a
than that.
week.
I've done worse than that.
I can tell you if we may work it. That would be nice.
It's, treating with a hot laser, you can't treat part of it because it's the tiger by the tail. It's just, you're gonna get bit.
So this is which kind of image is this?
I see it labeled as ICG
Good.
ICG sign.
of the right eye.
And you can tell that because you can see the choroidal, in the early one, you can see the choroidal vessels away from the lesions, which normally block the vessels. It's kind of cool. If you look at the left image, again, you can't see me, but you can follow the choroidal vessels under the RPE and then into the areas of atrophy, and you can see that you're seeing,
And
you're seeing the
they're
choroidal
confident.
vessels.
This dye is, I think, more protein bound.
Right, and in a different wavelength, so it goes through the RPE.
And then it too leaks.
And then
Yeah.
Eunice, or actually, and even seniors, on the right image, what are the dark spots on top? The little tiny dark spots on top of the ICG. Oh, those little guys.
There isn't blocking.
Yeah, those are drusen. Those are usually reticular drusen. So in the ICG, the reticular drusen kind of light up. So you can, especially in the late ICG, so sometimes late ICGs, you see all these little spots everywhere. Those are reticular pseudodrusen.
So they're not lighting up, they're.
Oh, yeah, they're
contrasting.
darkening up. They're
They're
striking.
standing out.
Standing, that's it, standing. Thank you. All right, go ahead.
And then an ICG of the left eye. Again, you can see kind of the choroidal vessels. Would this be considered like a hyperfluorescence as well?
Yeah, you can use fluorescence for this.
Fluorescence.
Yeah, absolutely.
And then hypofluorescent areas, kind of punctate areas
On the left image, you're saying?
on the right image.
The right image, okay. And then you kind of want to look for the change. So you see in this eye, this whole area is kind of turning kind of whitish. So you're seeing this diffuse hyperfluorescent area at 8 minutes becoming evident. And that generally means there's a blood vessel growth there in ICG. The idea is the ICG kind of deposits in the vessels and builds up there. and also probably is uptaken by the RPE. But they're called plaques. So it's a hyperfluorescent plaque in the late frames of ICG, generally means there's a neovascular membrane there. And the other reason to get an ICG, anybody know what's ICG best at for wet AMD detecting? There's one entity. Yeah, polypoidal. So I get ICGs not so much for that. In this case, you knew it's a neovascular membrane, but to rule out polypoidal, because polypoidal responds a little differently, and sometimes polypoidal does really well with PDT.
Yeah.
So if it was non-central, which it turns out it is, but for all you knew, when you got this ICG, you might have just a little lesion nasally, extrafoveal, with some feeder vessels that you might be able to PDT if you had to. So, but this is not polypoidal. There's no branching vascular network. There's no polyps. There's no nothing.
All right. So just going over the findings, there were some drusen in both eyes. There was a trace amount of intraretinal heme, it looked like, in the left eye. For the right eye, multiple sharply demarcated areas of RPE atrophy, so those window defects appearing like geographic atrophy. Without any staining in the right eye, without any leaking in the right eye, it seemed like. Left eye, OCT with sub-RPE hyperreflective material, subretinal and intraretinal fluid on the OCT in the left eye, and what appeared like non-specific kind of just progressive leakage on the fluorescein and the ICGA in the left eye. So what would be on the differential for this? We kind of talked about it a bit already.
The manifestations are like sequelae of macular degeneration, geographic atrophy, CNVM. I think she was also like a vasculopath, so like diabetic retinopathy, hypertensive retinopathy.
And I think one good way to organize differentials in your head, since you guys are younger, starting out, is by findings. That's why I like the findings. So, so you could start with, the geographic atrophy and say, okay, you see those little patches of atrophy in macular degeneration, but you also see them in retinal dystrophies and plaque lindle. This month's JAMA Ophthalmology has a atypical plaque lindle toxicity where they did genetic testing and it was Miller syndrome, I think. So it wasn't, which is kind of cool. But so there's genetic causes of geographic atrophy too. And then you can go to your exudation and say, okay, the exudation can be a neovascular membrane, it can be, so that one way to do differentials, which I think helps in your head. And then what happens is when you go through each finding and you go, okay, that can be wet macular or 5 things, that can be wet macular, then eventually your differential cones down to what satisfies more of your findings. I think if you do that in the boards, they'll give you a really good grade. I don't know who does board examination. You do that?
No, never was asked.
Yeah.
So the top 3 pattern dystrophy, adult onset vitelliform and central serous chorioretinopathy, those can be on the differential for both wet and geographic atrophy when it comes to AMD. So that would be like top 3 differential aside from, advanced AMD for this case, I believe. But otherwise, there's plenty of other causes for potential, CNVM, breaks in the Bruch's membrane that can allow those blood vessels to form and cause that leakage, including things like angioid streaks, pathologic myopia, chromatochoroidal rupture, ocular histo. But for this case, it was occult wet age-related macular degeneration with geographic atrophy. So this patient received Avastin monthly, and after 2 injections, the vision was 20/30, but their visual function had improved. And we have some images here. This is the left eye, and you can see there's this significant improvement in the infraretinal fluid here, significant decrease in the retinal thickness compared to, this is before and the bottom image is after. And here as well, significant improvement as well. So it responded very well to the anti-VEGF therapy. So I'm just going to talk a little bit about neovascular age-related macular degeneration. Macular degeneration overall is a pretty big topic, so I'm just going to focus on this. So damage to Bruch's caused by deposition of drusen provides a proangiotic environment that can lead to macular neovascularization. Before they would be referred to choroidal neovascularization, CNVM. The books are moving more towards macular neovascularization, or MNV, because the blood vessels don't necessarily originate from the choroid or the choriocapillaris. For the pathogenesis, VEGF has been strongly implicated in the pathogenesis of neovascularization in AMD, and tissue excised from patients with AMD from the actual macular neovascularization areas and in the vitreous have shown elevated levels of vascular endothelial growth factor. Specifically, vascular endothelial growth factor A seems to be the most implicated in wet AMD. Patients typically present with decreased vision, metamorphopsia, paracentral scotomas. That's why when patients have earlier stages of macular degeneration, we give them the Amsler grid and ask them to self-monitor covering one eye at a time. So when they begin to notice changes in the Amsler grid, they can come in for more urgent evaluation to see if there's any changes. So classifications for macular neovascularization. There's three basic types. Type 1 is called occult. This is when new blood vessels originating from the choriocapillaris break through Bruch's membrane, but they remain below the RPE. So I got some images on the right hand correlating to type 1, type 2, and type 3. So sub-RPE space. This can present with vascularized or fibrovascular pigment epithelial detachment. Type 2 is the classic choroidal neovascularization or macular neovascularization, where the vessels from the choriocapillaris break through Bruch's, pass through the RPE, and pass through RPE, and it's subretinal typically. This can present with kind of a lacy gray-green lesion. It would present differently on the imaging studies. I'll go into a little bit about that later on in this presentation. You can have a mixed type 1 and type 2, which is called minimally classic when it's both sub-RPE and above the RPE as well. And type 3 is retinal angiomatous proliferations. This is when the vessels originate from the deep capillary plexus in the retina and grow downward towards the RPE. So from here going downward. And I just wanted to touch upon this. So this is kind of the double layer sign. So when it comes to type 1 macular neovascularization, prior to any signs of intraretinal, subretinal fluid or hemorrhage, there may be some manifestations of macular neovascularization without the signs of exudation. This is called non-exudative neovascular AMD. This can be called that. It's easier to identify when you're using OCT angiography or ICG angiography. However, you can catch it on OCT scans, and that's what you're looking for, the double layer sign, which is a low-lying irregular pigment epithelial detachment with a heterogeneous hyperreflective subretinal space. So I provided some examples here. B is not an example of the double layer sign because this is more homogeneous, but C and D are good examples where the subretinal space, this is kind of more heterogeneous in appearance, as you can see. So those would be good signs of the double layer sign. And it's important to note because 14% of eyes that have intermediate AMD or geographic atrophy may have the double layer sign or have non-exudative neovascular AMD, and it significantly increases their risk for progression when you notice this sign from 4% to 21% for advancement to exudative AMD in the next year. Some just findings on fluorescein angiography that you may note between the three different types of macular neovascularization. So type 1, the occult macular neovascularization, can present with a fibrovascular pigment epithelial detachment, which may have progressive stippled leakage. You can have a vascularized serous PED, which would present on fluorescein angiography with rapidly pooling dye and a more homogeneous ground glass appearance like this on the image on the right side, and there may be noted a hot spot where the actual macular neovascularization is, and that would be over here on the image on the right. And it would also present with late leakage from undetermined sources as well.
Some people also call that a notch. If you see a pigment epithelial, like you see it's round and there's a notch, they'll say that's where the neovascular membrane is.
Type 2 you may know a more, sorry, this is still type 1 on the right image. This is just kind of a example of just kind of undetermined late leakage. So type 2 can present with a bright, lacy, well-defined hyperfluorescent lesion that appears early and progressively leaks into the late phase. So on the top image, this is the early fluorescein angiography image with kind of that brighter, lacy hyperfluorescing spot that progresses to late leakage. And that helps you kind of see what a classic macular neovascularization looks like. A mixed type 1 and type 2 can present, with findings from both type 1 and type 2. Type 3, the retinous angiomatous proliferations may appear as kind of a focal hotspot earlier on, because those vessels are originating from the deep capillary plexus of the retina. And then as the vessels extend down to the RPE layer, that's where you may have late pooling into a pigment epithelial detachment. So some findings on OCT. So OCT seems to be the most practical imaging for advanced macular neovascular, for AMD, for their follow-up, because you're seeing them pretty often, every month, 2 months to 3 months, depending on their treatment schedule. So for type 1 macular neovascularization, you may see it's type 1 macular neovascularization, typically limited to the sub-RPE space, where you may see sharply elevated dome with hollow reflectivity when you're looking at a serous PED. When you have a fibrovascular PED, you'll see kind of this lacy polyp-like hyperreflective lesions along the inner part of the pigment elevation. You may also see some signs of contraction, and you can kind of see how this is irregular as well. Type 2 macular neovascularization, you'll see hyperreflective material between the RPE and the retina. That's thought to be a mixture of kind of fluid, fibrin, blood, that macular neovascular membrane, and then other material, and it may have some associated subretinal and intraretinal fluid like the patient in this case did. And type 3, you'll see a hyperreflective foci emitting from the deep capillary plexus of the retina. That can be associated with CME and a pigment epithelial detachment. And when you think about kind of just what, type 1, the difference between type 1, type 2, and type 3, and, the origin of their vessels and where they extend to, that'll kind of give you an idea of what you would expect to see as well.
Can I just say the type 3s, we see all these people for shots with wet macular, scan. I'm like, you scan every visit here? Probably, most people do. I scan every second or every third, but you can scan every visit. And you're always looking at the fellow eye. And sometimes you see a little area of edema, not subretinal, but there's little intraretinal edema in the other eye. And it's almost nothing. And then a couple of visits later, it's like, oh, there's something going on there. And then eventually you realize that was a type 3. So sometimes like a little edema in the fellow eye is, you gotta watch that.
Do you know who came up with this?
No, who's that?
Gas, this old gas.
Oh, this is old gas, okay. Yeah,
It's old gas.
prior to OCTs, it's true. Kind of scary. Somebody told me his eyes were very far apart. I didn't realize that. And that's why he was so good at resolving.
I also had fantastic photography.
Yeah, his photography is very good.
And
Someone
so
told
they
me,
take stereo pictures.
we had our own scopes, but someone told me there's a time you had to go in, he would say, look at this, and you'd have to go into a scope, and you'd always have to pull the things together.
Yeah, but you don't get stereo pictures anymore, but they're fantastic, and he did this all with stereo.
Yes,
I'm sure that's how he could figure it out.
Yeah.
The layers, because we didn't have OCT, but he figured it out.
All right, go ahead.
And just talking about the management. So earlier, I think you were talking about laser photocoagulation. It's rarely used in this nowadays, given the advent of anti-VEGF treatments. But before it was used, however, there were high rates of recurrence. There was risk of vision loss, and often it would fail to improve the vision when it was used for the macular neovascular membranes. There's also photodynamic therapy. It was used in the past as kind of a safer alternative to photocoagulation initially. It did show some benefit, but it only kind of showed kind of more slowing initially of vision loss, but not really preventing that vision loss from the macular neovascularizations. Nowadays, It's mostly used kind of, you think you talked about it earlier, on polyploidal choroidal vasculopathy. It's used in conjunction with ranibizumab. So there was a study, I think it's an Everest trial or something, where ranibizumab plus PDT was shown to be superior to just ranibizumab injections. But there was also another study showing that aflibercept was not inferior to aflibercept plus PDT. So I'm not sure what the trend is in terms of using this to treat for polyploidal choroidal vasculopathy. But it's still an option, but it seems to be kind of more not used for wet AMD nowadays.
I think most of us do anti-VEGF, and then if you get a resistant case and it looks like there's something you can hit, you call it the PDT.
Nowadays for treatment, the primary mode of treatment is anti-VEGF therapies. And there's kind of three broad strategies for treating in terms of dosing, which is kind of a fixed dose, an as needed dose where you monitor them, and if there's any signs of exudation, you would treat, and then a treat and extend method, which is when you treat till it appears that there's no exudation, then say you're treating at maybe Q6 weeks, and you would extend it to 8 weeks and then 10 weeks. And then 12 weeks until you begin to note signs of exudation, then you'd revert back to the previous dosing schedule. So kind of back to Q10 then, if they begin to have signs of exudation at Q12. So that would be the treat and extend method, and that seems to be the most common method nowadays. So I'm just gonna kind of go over VEGF a little bit because it's, we use it all the time for AMD, and it's, a big topic.
Can I talk?
Sure, absolutely.
I want to interrupt you.
Former chief.
I don't think you realize how much the anti-VEGFs improve vision. Before, if you used the hot laser, the difference was you either lost 4 lines of vision or you lost 6. And that difference was what made laser effective. But think about it, you're still losing like 4 lines of vision. I can show you the graphs. I looked them up. With PDT, I think you get initial acuity improvement, and then you go right back to your baseline over time. It doesn't hold. The first therapy to show a dramatic increase in vision, I think, by more than 3 lines, and holding it was Lucentis, and you had to give it every month. And God bless his little black heart, but Brizard was right. He said, once you make the decision to treat, forget everything else. Just hit the patient every month. The problem is, every time you prep the patient, it is misery for them for a couple of days. I mean, you put in what's the betadine?
Yeah.
Even the ophthalmic betadine, it's just horrible for some patients. And so they're down. They literally lose 2 days at least every month. So there's a much motivation to try to figure out how to drag it out. But as you do that, you lose acuity. So you get this increased improvement in acuity, and then you slowly go back to baseline where you were. But if you give it every month, it holds, and it went out 2 years. It was amazing. But Grizzard was right. Just forget about everything else. Forget the testing. Just do it.
Yeah, now the newer ones are different.
Yeah.
You can.
Yeah. Okay. Well, I quit 4 years ago.
And the other thing that was we weren't in the initial trials, but people said in the initial Lucentis trials, you could tell who the placebos were.
Yeah.
Because they lost vision,
Yeah,
the other
yes.
people didn't. I mean, only 5% of people on treatment lose vision, and without treatment, it's not 100. It's funny, all these diseases, nothing's ever 100. But without treatment, about I think 70 or 80% of people lose vision.
But it was truly amazing. And the other
They
thing
made
is,
their money off it.
And you didn't
Holy
have to
cow, they
like
made money.
decide what.
yeah,
type
but
of
they
membrane.
deserve it.
Yeah, they.
I mean, if you don't
deserve
provide,
some of the money.
if you don't provide a profit motive for
Yeah.
a private company, you're not gonna have private companies. And it wasn't the government who
Right.
did this.
No.
I am sorry, I'm
I
a
heard at
Democrat.
one point they
I'm a
were.
Democrat,
I
but
heard
it
at
was
one
not
point
the government.
10%
Government can't do
government.
crap,
All right, go ahead. This is a good time. You're doing a great lecture, guys.
Sorry, we're getting that little far field.
Yeah.
So there's 5 distinct types of cytokines when it comes to VEGF, and VEGF-A I think was the initial one discovered, and it's the primary one implicated in wet AMD. And when it binds to the receptors, VEGF VEGF-R1 and 2. It promotes, angiogenesis, vascular permeability, and prevents apoptosis, leading to that neovascularization. And I believe there's 5 FDA-approved anti-VEGF intravitreal injections for exudative AMD. And then there's bevacizumab, which is used off-label to treat exudative AMD as well.
I think we're up to about 10.
Oh,
We got a lot.
sounds like there's more coming out every day.
Yeah, sure.
I'm just gonna kind of gloss over quickly some of the kind of how it started out and some of the more prominent trials. So the initial first anti-VEGF treatment that was FDA approved was pegabetinib, approved in 2004. However, it's fallen out of favor due to it being less effective than the other current anti-VEGF treatments. And I believe that's primarily because it's mostly targets the VEGF 165 isoform, where our other ones are much more broad in terms of their interaction with the multiple types of VEGF, I believe.
Yeah, that first one didn't do anything. It was interesting, if you read the initial papers on Macugen, there was not a dose response curve, which really should have been a red flag that it didn't actually do anything. So you found at the lower dose, it did more than at the higher dose, which suggests that it was just a
Because
statistical.
our current treatments are such.
Yeah, and then the
time,
pan, but I have to say, in their defense, they were trying to be safer. So they were trying to do a drug that didn't do so much to the eye, but then the other one came in and knocked it out of the park. But it did tell you could do shots in the eye frequently. And the idea of doing shots in the eye frequently was just kind of crazy.
Well, that was the AIDS epidemic.
Yeah,
cyclogen.
Yeah, I did
Yeah,
a lot
those
of
were-
them
yeah.
in residency because of.
Yeah.
All right, go ahead.
You were the one.
Memory
who
lane here.
You could get very high doses
We
of
gotta keep going.
encyclopedia, right?
So the Anchor and the Marina trials they're emphasized in the BCS, so I think we're not worth memorizing as well. So these were kind of the two. So these two are very prominent trials for testing ranibizumab. They were given 1 month every 1 month for 24 months, with the primary outcomes being number of patients losing less than 15 ETDRS letters, and the secondary outcome being number of patients who gained more than 15 letters. Anchor was compared to so patients receiving ranibizumab plus sham PDT versus patients receiving sham injections versus real PDT. And the Marina was just ranibizumab injections versus sham injections. And at the bottom, you can see the significant difference when it comes to the amount of patients that lost less than 15 letters, more than 90% of patients versus the 66% of patients who only received the PDT. And a significant portion of patients had a significant improvement in visions, more than 15 letters in the patients who received the ranibizumab versus PDT, and in the Marina studies as well, with very similar findings. So significant improvement in vision and significant preservation of vision as well. So 1 month was a lot of when it comes to injections. So they tried to dose it out with the Pure and Excite study, doing 3 initial loading doses and then kind of going down to every 3 months. But that was shown to be inferior to the original Anchor and Marina study. So you can see these visual outcomes kind of initially were good in the Pure study, and then it kind of falls off in visual acuity because Q3 months was not sufficient enough for those ranibizumab injections. They then tried to move on to kind of trying some PRN injections where the patients would be monitored, after the 3 initial loading doses. They were monitored kind of for signs of exudation, and that would be then when they were given the injections. And those studies reported either, comparable visual outcomes or less favorable visual outcomes when compared to the Marina and Anchor study. And there is the Trend study, which is kind of tested the treat and extend method for testing ranibizumab, which I talked about earlier, how they would kind of be extended out until signs of exudation were appreciated, and then they'd go back to the previous dosing schedule. And at 1 year, patients received 8.7 injections in the treat and extend method, whereas I believe they received like 11.1 with the dosed Q1 month, and it was shown to be not inferior at that. So it was shown to be not inferior, allowing you to kind of give less dosing while maintaining that quality of vision. Going over bevacizumab a bit, this is a not FDA approved, but it is treatment for AMD, but it is used often because this is the full monoclonal antibody that from which ranibizumab was derived, has a longer intravitreal and systemic half-life because of its larger size. It's also significantly less expensive than ranibizumab, from my understanding. And the main study to note for this is the CATT study, CATT, that showed it was not inferior to ranibizumab with when they was dosed as Q1 month injections and with PRN injections as well.
It's interesting, Phil Rosenfeld gets credit for saving Medicare billions and millions of dollars by trying this. And I have to say, when this was first tried, I remember actually Iyer told me about it, our associate who came in.
Oh, yeah.
People didn't think it would work. It shows you how you sometimes you have to try things, I guess, in medicine because it's too big. The molecule should not be able to traverse the retina. Based on the science, but somehow it gets to the neovascular membrane.
I remember.
So no, and I don't know that that's actually been figured out, how a full-size antibody can traverse the retina.
But I remember when he announced it at the Vitreous Society.
Oh, Phil?
And there were like 500 people in the room, I don't know, maybe 300. And you could hear a pin drop when he mentioned it.
Because they initially gave it systemically, but it was so hard.
Yeah.
If you give it systemically, like a cancer dose, but it's hard on your system.
Oh, it's terrible.
Yeah,
So he said, well, if you work it out, it's got each molecule has two active arms, whereas the Lucentis is only one molecule, so one active arm. But if you work it out, straight out of the bottle, it's about the same dose as what you give, same volume. And he did it, and it was successful. And boy, did the company, they were.
Yeah, Genentech stock went down 10%.
They were mad, and they tried to restrict it, and they can't do it.
The other weird little twist in it was, I think with a year or two ago, some company tried to do an FDA trial to show bevacizumab was useful, so they could take it off they could put it on label instead of off label and upcharge it. And the FDA actually said, we're not doing this game. And they said, we're not gonna.
Good for them.
Which was, everybody's really nervous. There was this thing where, because there's a law that you're allowed to take generics off generic if you do a trial. And someone tried that with bevacizumab and they somehow which was nice.
Isn't that the phenylephrine that
Yes. Okay, keep going. You're doing well.
Yeah. Old people like me wander, I'm sorry.
So there's also aflibercept, which is kind of a VEGF receptor trap. It binds VEGF-A, B, and the placental growth factor. And when I was reading online, it said the binding of placental growth factor is a reason why it might be effective for other cases that are refractory to other anti-VEGF treatments. So it was tested with the VIEW 1 and 2 trial, which which was a non-inferiority study compared to ranibizumab, where they were dosed, I believe initially with 3 loading doses and then Q1 month and 2-month injections. And it was shown to be non-inferior in terms of visual acuity and anatomical improvements on OCT. The VIEW 1 and 2 study are worth memorizing because they are emphasized in the BCSC as well. In 2023, there was a high dose formula for aflibercept as well, at 0.8 milligram and 0.07 ml, which was approved by the FDA, and the Pulsar trial tested, and it showed that it was not, the 8 milligram dose given Q12 and 16 weeks was not inferior to a 2 milligram Q8 week dosing for wet AMD. And at 2 years, 88% of patients maintained a greater than 12-week dosing interval.
That's one of them, Vabysmo is the other one.
This is also another FDA-approved treatment, Rolizumab. I haven't seen it used. The Hawk and Harrier trials were a non-inferiority study comparing this to aflibercept, and it was shown to be, non-inferior in terms of visual outcome, but there were some findings of an increased risk for intraocular inflammation. 4.6% of patients developed intraocular inflammation with retinal vasculitis and vein occlusion, compared to only 1.1% of aflibercept treated patients. I think this might maybe be the reason why it's not.
Yeah, everybody stopped using it because the other ones are so safe, and it was too bad because I thought that was going to pull the market. I liked it. I had patients who
You lose
responded.
money on
to
it?
that. What's that?
You lose money on the investment?
No, I don't actually invest in, I don't invest in stocks. If I pick a stock, it goes down.
That's good.
But,
If you tell me, we can sell it short.
Yeah,
Yeah.
the bonus isn't that. But they, yeah, but they should have taken the market, but they had safety. The drugs are so safe, which is weird because they shouldn't be as safe as they are because they're proteins and you would think they'd cause trouble, but they're just really safe. So that was it. And it was a very low risk. I think in the end it was 1 in 100,000 or 1 in 10,000, the catastrophic event.
But
But
a
it was still-
catastrophic is a
Yeah,
catastrophic
catastrophic.
event.
If there's none with the other ones.
Yeah, this recent problem I had
Yeah,
with my stent,
yeah.
with the vessels growing in the middle of it. 3%, but 3% is 3%. If
Yeah,
you
when
want
it's
part
you.
of it, yeah.
All right, good job, Vishnu.
And
Sorry
last,
about all the interruptions, but I enjoyed it.
last one is, Vabysmo or faricimab, a bispecific antibody targeting angiopoietin-2 and VEGF. The Tenya and Lucerne studies were a non-inferiority study comparing it to aflibercept. And it showed, testing kind of, I think it was, and almost half the patients were able to maintain on a Q16-week dosing schedule. So that's kind of the trend with the newer medications, trying to further extend out their treatment. And kind of the newer medications are able to go significantly longer than the earlier ones. Any questions?
That was great, thank you.
What about the reservoir, guys? Tell me about.
Oh, the Susvimo. So it came off the market. I guess more than anybody in Florida. I put it because we were in the study, so I put a couple in. And there was a problem with the diaphragm dislocating with the refills, which are really hard to do. And then it just came back on the market a year ago. And so
Anyone using it?
I got a couple patients. I have a couple snowbirds that are so unhappy with their doctor up north that they fly back to see me.
Yeah, I
With
can
the
understand
shots,
that.
because the shots are, we worked it out, and so the snowbirds, I got 3 people, I think, queued up for the implant, because the implant lasted, there's an FDA approval thing that you have to be careful with. The implant's approved for every 6-month refills, but in the studies, the phase 2 study didn't require refill. And in the phase 2 study, I think about 90% of people went almost a year. So most of the implant really probably goes a year.
Wow.
Which is
Terrific.
nice. Refilling it is like trying to blow up the Death Star. It's so hard to get, the needle, the port for the needle is so small that unless you like hear a voice in your head at an angle, it's really hard. Putting them in is nothing. You can put them in like that. Putting them in is nothing, but refilling them, I can't stand, and I can do all sorts of things, but refilling these is probably my biggest challenge.